Well, good afternoon. As you can see on the agenda, I was originally asked by Bob Wong to talk about our clinical research in lupus nephritis, but I thought this esteemed group of neuroscientists would rather hear about neuropsychiatric lupus, so that's what we'll talk about. Systemic lupus is the prototype autoimmune multisystem rheumatic disease. It primarily affects young women of childbearing age, but can be seen in children. It can be seen in men, but with a female to male ratio of about 9:1. At Downstate, we've had a lupus registry, which actually began in the late 1960s and over time has included well over 2,000 patients. The features of systemic lupus, one very important feature is the immunologic abnormalities, and some of the autoantibodies are highly specific for systemic lupus, such as anti-double-stranded DNA antibodies, the anti-SM antibody, whereas others are more generalized and are seen in a number of rheumatic diseases. The anti-nuclear antibody is seen in at least 98% of lupus patients, but can be seen in other diseases. Antiphospholipid antibodies, which are also seen idiopathically without any other disease or in rheumatic diseases. The most common clinical features are mucocutaneous manifestations, the classic malar rash, alopecia, loss of hair, skin lesions such as discoid lupus, which are all characteristic of systemic lupus, and musculoskeletal manifestations, primarily arthritis that resembles the arthritis of rheumatoid arthritis. The most severe internal organ manifestation and the most common is renal disease, but the most poorly understood, puzzling manifestation of systemic lupus are the neuropsychiatric manifestations. And here you can see on the slide 19 specific neuropsychiatric definitions, which were done by the American College of Rheumatology. And the ones that are the most puzzling are the global ones: seizure disorders, cognitive dysfunction, psychosis, and acute confusional states. Most of the peripheral nervous system manifestations are easier to understand in terms of their pathophysiology. So for those global manifestations, even when we can't identify a specific cause, they're frequently associated with other features of active lupus, but they may also occur alone. So the neuropsychiatric pathogenic pathways in lupus predominantly fall into two groups: those that tend to be ischemic versus those that are inflammatory. And the ischemic ones, again, are relatively easy to understand. They may be related to vascular events such as thrombotic events or atherosclerotic events. The antiphospholipid antibodies often contribute to the thrombosis. Steve Levine, who spoke to you, is also an expert in this area. So you may hear more from him at some point in the future. The inflammatory mechanisms are clearly part of the active process of active lupus. Cytokines are produced, autoantibody antigen complexes are produced, and somehow they need to cross the blood-brain barrier in order to get into the brain, whether it's into the nucleus or the cytoplasm. So this is something that we've been looking at for a number of years, and as part of this, our lupus registry has been part of a collaborative group called SLIC, which is the Systemic Lupus international collaborating clinics, which also goes back well more than 30 years. And it's a group of collaborators at academic institutions in virtually all over the world, in a lot of sites in the United States, others in North America, in Canada, in Europe, in the Far East. As part of SLIC, we started an inception cohort to look at, the original aim was to look at risk factors for atherosclerotic disease in lupus, but this was extended to look at neuropsychiatric manifestations. And some of our early studies in the cohort now is over 1,800 patients, and it's actually closed now after a minimum follow-up of 10 years, and many of the patients in over 20 years. So early on, with about the first 400 patients, we looked at the frequency of serum antibodies in patients in the cohort and looked at whether they had features of neuropsychiatric disease. And as you can see from this, that there is virtually no correlation. Some patients who had manifestations did not have any of these serum antibodies, and a number of patients did, but there was not a single one of these autoantibodies that one could say really were predictive of the development of neuropsychiatric manifestations. And the final follow-up, which the follow-up of the inception cohort was actually closed this year, and published, so that, as you can see, there were almost 1,200 neuropsychiatric events among 955 of the patients in the entire cohort. And again, they were very varied. Some were thought to be due to active lupus. Others were thought to be due to contributing factors such as atherosclerosis, strokes, infections, medications, steroid complications. But fortunately, in our cohort, this led to a wonderful collaboration with Dr. Henry Tiget, who unfortunately is not here today because of a COVID exposure. So after I show you this initial data, I'm going to make some attempt to provide a little bit of the data from his talk. So I promise there won't be another full 8 minutes. Before COVID, Henry came to me and asked me if I had serum on any of our lupus patients who might have had seizures. And I provided to him a sample of our patients from our serum bank. This was cross-sectional. Most of the specimens I gave him were single specimens. There were a couple of longitudinal specimens, but they were all from patients who had seizures right around the time that the serum was collected. And this serum was old. It was in our minus 80-degree freezer for at least 10 years. So obviously this antibody was stable. And as you can see from this, he also had controls of patients without lupus, patients with other autoimmune diseases, and patients with non-rheumatic diseases. And the only patients who he identified to have antibodies to the brain cytoplasmic RNA that he was studying were in our patients with lupus, predominantly those who had evidence of seizures. And you can see this here. So to explain a little bit further about Henry's research, I'm going to read to you his description of the mode of action of his anti-BC antibodies. The delivery of BcRNAs to synaptodendritic domains requires transport factor HMR-NP-A2. The factor interacts with targeting determinant structural motifs contained within BcRNA 5' stem loop domains. SLE anti-BC autoantibodies bind with high affinity to the same motif structures, displacing HMRNP-A2 from BC RNAs, and therefore cause impaired dendritic delivery. We know from animal models that lack of BC RNA translational regulators at the synapse can result in excessive local protein synthesis, neuronal hyperexcitability, and seizure susceptibility in vivo. So we went on from there to his further experimental model, which I'll show you. Unfortunately, Henry had some fantastic videos, but on short notice, I couldn't really bring them along. But the picture on the right shows you his experimental system with a mouse in a cage, and he used naive wild-type mice with a permeabilized blood-brain barrier. They were injected IV with patient sera or with total IgG preparations from the patient sera. 4 days later, the animals were examined for seizure susceptibility. And this was done by using an auditory stimulus, which apparently causes seizures in these mice. The animals injected with either the sera or the IgG preparations, as you can see, from our lupus patients, and also from another collaborator from our SLIC group that had the anti-BC reactivities and a history of seizures, all succumbed to this generalized stimulus, this noise stimulus. Very impressive if you could see it. They immediately had tonic-clonic seizures, and they all died within a minute. In contrast, when he took litter mates that were injected with the same lupus sera, but that had been neutralized with BcRNA, the mice were as happy as clams. They heard the noise, they continued to run around in their cages, and nothing happened. So this rescue was 100%, which basically means that the seizure phenotype of these animals is solely caused by the autoimmune reactivity against the BC200 RNA. He used other autoimmune preparations from other antibodies, and they did not produce the same seizure activity. The thing that, to me, as a clinician, that's very exciting about this is twofold. As I said, the original serum samples that I gave him were cross-sectional. We subsequently had a young patient who was admitted with status epilepticus, with just recurrent tonic-clonic seizures. And fortunately, he lived through the episode, was treated with corticosteroids, with immunosuppressive drugs, as well as anti-seizure medications. His serum from that episode was strongly positive for the autoantibody. A year later, he was doing extremely well, and we repeated his serum studies, and his autoantibody levels were barely detectable. Now, this is the first of the samples that I gave him where we had longitudinal follow-up and history that the patient had initially had seizures and had completely recovered from the seizures. In fact, he's now off of anti-seizure medication and is still seizure-free, and his lupus is in remission, which is, I think, truly remarkable. So there are two implications here. One is that that this test may be a prognostic indicator of outcome. We know that seizures are not a very frequent manifestation of lupus, but if we can routinely test this autoantibody, at least at presentation, we may have an idea of whether patients can be expected to develop seizures or even some other manifestations. Henry's about to look at cognitive deficit as well. The other is that since you can neutralize this autoantibody, it may even have treatment implications, that rather than having to treat patients with a general immunosuppressive drug, which can be very toxic, we may be able to treat especially those patients who have either recurrent seizures or status epilepticus with a neutralized antibody. So I thank you.